and as as friends and colleagues take this to the next level and bring it to patients with early stage disease. So we'll start off by really laying the land here, and really the person who's going to give us that best is a medical oncologist who's an expert in treating these diseases. So Marina Beretti from Johns Hopkins, she's an assistant professor at Johns Hopkins, who is a very integral part of their hepatobiliary GI oncology team. And she's going to start off by giving us kind of the lay of the land of the treatment landscape for HCC and biliary tract cancers, and that'll really springboard our discussion into early stage disease. So Dr. Beretti, I'll hand it over to you.
Thank you so very much for inviting me to join this very esteemed group of colleagues today. I'm going to start by sharing my slides, and hopefully you can see them. So as I mentioned, I'm a medical oncologist, and I think until a few years ago, this talk would have been very short, and now I feel like 15 minutes will not be enough to discuss all the advances that we have made in the management of both HCC and biliary tract cancers. These are my disclosure. And I switched a little the talk. I'm gonna actually start by talking about biliary tract cancer. And this is a slide where I've really tried to summarize all the progress that we have made to give you a sense of the many treatments and drugs that have been approved, both in terms of target therapies as well as immunotherapy. What we know about biliary tract cancer, and this is probably obvious for many of you, but this is a very diverse and heterogeneous group of malignancies. Unfortunately, the incidence is rising and the prognosis remain still very poor, perhaps due to the limited rates of efficacy of old-fashioned chemotherapy. So one of the big advances in the last few years has been the approval of immunotherapy in the frontline setting. And these are the two big studies that led to their approval. And the premise of these studies in both cases was trying to see if by adding immunocheckpoint inhibitor to standard of care chemotherapy, we could increase our chance of harnessing an immune response, and that could translate in better outcomes for our patients. The very first study that was presented was the TOPAZ study. This was a randomized, multi-center global study in which patients with advanced stage metastatic biliary tract cancers were randomized to either receive what was the standard of care, the combination of gemcitabine cisplatin, versus the same combination with the addition of the anti-PD-L1 durvalumab. One consideration of the study is that in both arms, chemotherapy was continued for up to 8 cycles, which is approximately 6 months. And then the chemotherapy was dropped in both arms, which means patients either continued durvalumab, single agent, or placebo. And here I'm just presenting the most updated survival curves. This was a positive study. The primary endpoint of overall survival was met with a median overall survival of 12.9 months for the triplet versus 11.3 for the doublet, and a hazard ratio of 0.76. I think it's interesting to see that the curves tend to overlap during the first 6 months when we have chemo in both arms, and then they diverge. But it's also clear looking at these Kaplan-Meier curves that there are this long tail of survival. For instance, if you look at the 24 months landmark, we have approximately 24% of ongoing survivors versus only 11% in the control arm. TOPAZ study was also positive in terms of improvement of progression-free survival and response rate, although you might argue that the chemotherapy underperformed in this case. There has been a lot of efforts in trying to understand if we can identify a subset of patients that can have the most benefit from the addition of immunotherapy. But so far, this post-hoc analysis have overall shown a benefit from the addition of immunotherapy in all the subsets, including in different molecularly selected subsets, with a caveat of low prevalence of some of the genetic alteration in the patients included. And after TOPAZ, we had then the presentation of the Keynote 966 study, very similar study, again, looking at the addition in this case of the anti-PD-1 pembrolizumab to the chemo gemcis versus gemcitabine alone in the control arm. This is a larger study, and I think what I want to point out in this case, after the first 6 months in both arm, patients did continue gemcitabine monotherapy plus or minus pembrolizumab. In this case, also, the majority of patients were enrolled outside of Asia, so perhaps a little more representative of a global population. And again, we have the second, positive study in the frontline setting. These are the curves for overall survival. The median overall survival was improved from 10.9 months to 12.7 with an odds ratio of 0.83. But again, perhaps outside of the median survival improvement, I think what is interesting to say, if we look at clinically relevant landmark endpoint, we do see a higher proportion of survivors in the combination with the immunotherapy versus the chemotherapy alone, really making us thinking that there is a subset of patients that can have a major benefit from this type of approach. In this keynote study, we didn't see a statistical significant improvement in progression-free or overall response rate. But if you look at the characteristic of response, it's clear that the median duration of response is higher with the addition of pembrolizumab. For instance, at 24 months, we had 18% of ongoing responses versus only 6% with the chemotherapy alone. And so really now this is the new standard of care in the frontline setting. With these two large phase 3 studies have established the addition of immune checkpoint inhibitor to chemotherapy as a sort of standard in an unselected patients population. And I want to also point out that as expected, the incidence of immune-related adverse events was higher with additional immunotherapy, but overall the incidence of grade 3 and 4 adverse events was comparable between the arms despite the addition of immunotherapy, speaking of the safety of the approach. There has also been now interest, I just want to point out, as mentioned before, of looking at this type of approach and translating this in the earlier stage. This is one of the neoadjuvant studies that we have at Hopkins, but similar studies are also open elsewhere, for instance, at MD Anderson. There has been also a lot of interest in trying to intensify the chemotherapy per se. And some of the interest was sparked by this study published in 2019. This was a non-randomized phase 2 study looking at gemcitabine cisplatin plus nab-paclitaxel, also known as Abraxane. It was a very impressive study because you can see here a response rate in the 45%, including a number of patients who were able to be downstaged back to surgery when initially were they considered unresectable. So this was the background to a large phase 3 study looking at this triplet combination versus the standard of care at that time, gemcitabine cisplatin. A study that really had, I think, record time in terms of enrollment. However, and unfortunately, perhaps the study failed to show an improvement. There was no statistical significant difference in overall survival, nor in response rate or progression-free survival, although you can argue that numerically the triplet did perform a little better. But in this case, the safety is of a consideration because there were high incidence of grade 3 to 5 adverse events, mostly related to myelosuppression. I think for the purpose of today's discussion, it's interesting to see that if we look at subgroup analysis, there seemed to be a trend towards a better outcome with this triplet in patients with gallbladder cancer, as well as with locally advanced disease. And perhaps this is a signal that still deserves further investigation. But as I mentioned before, biliary tract cancer are very heterogeneous, and this heterogeneity is not just related to the anatomical location. More and more, we are classifying these patients based on their molecular characteristics, and some of these have especially relevance from a therapeutic standpoint. One of the very first target therapy that was approved for cholangiocarcinoma was ivosidenib, which is an IDH1 inhibitor. IDH1 mutations are mostly seen in the intrahepatic cholangiocarcinoma subset. Approximately at 20% of these patients have these alterations. And the drug was approved based on this Clarity study, which was a phase 3 study, placebo-controlled and double-blinded, looking at ivosidenib versus placebo in patients in the second and third line with advanced stage biliary tract cancer. Because it was placebo-controlled, a crossover was allowed at the time of progression, and progression-free survival was chosen as primary endpoint. You can see here the primary endpoint was met with an odds ratio of 0.37, although perhaps numerically these numbers are not that impressive, but there is a clear differentiation and separation of the curves that is maintained over time. The analysis of overall survival was a little more complicated. In the intention to treat population was mostly clouded by the crossover, but when adjusted by crossover, we also see an improvement in overall survival. I think what is important to note for patients, but also from a surgical standpoint, that this drug is mostly a cytostatic drug, meaning that mostly leads to stabilization of disease. Real partial response are rare, although there is a subset of patients that can have this profound and durable stable disease. And I'm not going to go into details, but one of the questions with any target therapies is the emergence of secondary resistance, but this has already led to development of novel drugs that hopefully will continue to change and improve the management of these patients. And in terms of targets for cholangiocarcinoma, a lot of interest is around FGFR2 fusions. These are more rare, approximately perhaps a little less than 15% of patients, again, mostly, almost exclusively seen in intrahepatic cholangiocarcinoma. And one of the most recent drugs that has been approved in this setting is futibatinib, which is an irreversible FGFR2 inhibitor. And here we have the study that led to the approval. This was a study in 103 advanced stage cholangiocarcinoma patients in the second line setting. And you can see here very impressive response rate of 42%. With a median duration of almost 10 months. And that translated in improvement in median progression-free survival, impressive median overall survival of almost 22 months. And these data are particularly striking if we look at historical data in a refractory patient population with old-fashioned chemotherapy as well. So in the FGFR2 setting, we actually have 2 drugs approved. I think with all the bias of cross-trial comparison, we have a very similar activity. And I think the bottom line is how important it is to test patients for these alterations so that we can offer them the best target therapy that can really change their outcome and sometimes perhaps even the stage of disease. So far, we have talked about alterations that are more common in the intrahepatic cholangiocarcinoma, looking at gallbladder cancer, extrahepatic cholangiocarcinoma. One of the most common alterations are HER2 amplification, up to, again, perhaps a 20%, perhaps even higher number of patients. The initial drugs that were approved or at least available in this setting was the combination of trastuzumab and pertuzumab based on the MI pathway. But recently, there has been a lot of development, drug development in this setting. And the study that I really want to highlight is the Horizon BTC study, because this is the largest study for HER2 positive biliary tract cancer, looking at zanidatamab, which is a HER2 targeted bispecific antibody. Very impressive response rate, again, in the 40% range, with median duration of response in the 1 year. This drug is not approved, but this might change in the near future, and now is also tested in the frontline setting together with chemotherapy. And for HER2, just for completeness of data, I do want to mention the recent FDA approved in a tumor agnostic manner of trastuzumab deruxtecan. And again, I think the bottom line is how important is that we test patients for these alterations for which we have available and very effective target therapies. So just to summarize, immunotherapy is now part of standard of care for patients with biliary tract cancer. Next generation sequencing should also be considered standard of care. In my mind, we still need to understand how to better use these drugs, including the stage where to use the drugs, and perhaps try to understand what is the connection between the immune and the tumor immune microenvironment and the different molecular subset will be important for us to development and more precise type of therapies as well. And I'm going to switch to hepatocellular carcinoma very quickly. Again, another field where we have made important progress here. I've tried to summarize on top the drugs that are approved in the front line, and on the bottom, the drugs that are approved in the second line setting. And one of the big kind of revolution for hepatocellular carcinoma management was with the IMbrave 150 study, which was looking at the combination of the anti-PD-L1 atezolizumab versus the anti-VEGF bevacizumab in advanced stage hepatocellular carcinoma, compared to what at that time was the standard of care, the TKI sorafenib, a large study which even included patients with main portal vein thrombosis, and a totally very positive study. You can see here updated overall survival curves with a median overall survival of 19.2 months versus only a little over 1 year with sorafenib, an impressive odds ratio of 0.66. And I think what is very striking about the IMbrave study and this type of combination is also the response rate, which is up to 30%, including 8% of patients that can have a complete response and very durable response up to 18 months. The potential downside is the toxicity with bevacizumab. We need to be aware of the risk of bleeding in a cirrhotic patients population, especially variceal bleeding is of a concern. So this patient need to have had an EGD within 6 months before starting therapy. After the IMbrave 150, another important advance for HCC management was with the study Himalaya, in this case looking at immunotherapy combination, looking at the anti-CTLA-4 tremelimumab, one single higher dose, plus the durvalumab anti-PD-L1. This is called STRIDE regimen. And the Himalaya, there were 3 arms and 2 comparisons. The main thing was to try to show that the STRIDE regimen was superior to sorafenib. And then the second comparison was to show the not inferiority of single agent durvalumab versus sorafenib. What is very striking about Himalaya? This is the largest phase 3 study in frontline for HCC. And now we have survival data at 5 years that I'm showing here. So you can see that at 5 years, almost 20% of ongoing survivors in the STRIDE regimen versus less than 10% in the sorafenib. And you can see an improvement in the median survival from, again, around 1 year to 16 months with the STRIDE regimen. In this case, with the STRIDE regimen, the response rate is lower, approximately 20%, but it's clear that if you have some form of response, either stable disease or partial response, those are going to be the patients that tend to have also a better outcome. A similar strategy was also tested in the CheckMate 9DW, but in this case, it's the combination of anti-PD-1 nivolumab plus anti-CTLA-4 ipilimumab, and this is another positive study. What is striking about the CheckMate 9DW, the control arm was either sorafenib or lenvatinib for physician choice, and actually the majority of patients ended up receiving lenvatinib. Nevertheless, the combination of immunotherapy did improve the median overall survival with an odds ratio of 0.79 and median overall survival that now are almost 2 years versus 20 months with the TKI monotherapy. And again, looking at some landmark endpoint, for instance, at 36 months, we have 38% of survivors versus 24% for the TKI, really speaking of the significant and durable benefit from nivolumab plus ipilimumab. Another striking data about the nivo-ipilimumab combination are the response rate, which are now up to 36%, again, almost 7% complete response with a median duration of 30 months. So real responses that can really change the outcome of our patients. There is a little higher incidence of immune-related adverse events, including those leading to discontinuation, but actually the authors did look at quality of life and symptoms control, and all those criteria did favor immunotherapy over TKI. So where we are for HCC, we now have a different positive study in the frontline setting, impressive survival with the median, they go from 16 to almost 2 years. We didn't mention, but we have also proven progression-free survival benefit with the addition of immunotherapy to intermediate stage patients. I think we do need to do a lot of progress, and where there are many open questions in the early stage. As of today, we do not have any approved perioperative regimen. Many studies are ongoing. So really try to really understand how to better sequence and select patients is an open question, as well as, the search for better biomarker for patient selection, I think is really an unmet need. And with that, I really want to thank you for your attention.
Excellent. That was absolutely fantastic. A wonderful tour through, very exciting times. Lots of new drug regimens and combinations, particularly in the BTC space as well, with all the targeted therapies. I think one thing that's very clear, immunotherapy is here for hepatobiliary malignancies, although the effect in BTC a lot less impressive and more modest than what we're seeing in HCC. So with that fantastic foundation, we'll move over to Hoptran Cow now, from attending at MD Anderson. Again, very integral part of their hepatobiliary program, leading lots of interesting research and a robotic program at MD Anderson as well. But we're really talking about how do we apply all the data that Dr. Breddy just went over with us to a surgical practice, and really honing in on the importance of clinical trials to take this forward. So Dr. Cow.
Thank you very much for having me. Appreciate it. And yes, excellent presentation, Dr. Biliary. Thank you for laying the groundwork for me and making things easier for my presentation. So let me start the presentation. I do have a Merck research grant to disclose. Today, we're going to talk about first why it is important to have clinical trials in the resectable setting. Dr. Biliary has kind of shown us what in the advanced unresectable setting, what changes have come about in the last, I'd say, decade or so, which is very exciting for us. But it's important for us surgical oncologists to think about how this is going to be applying to our perioperative settings. So it's important to remember that operability on imaging criteria or anatomic criteria does not necessarily mean resectability. This is an example of a patient with a large intrahepatic cholangiocarcinoma. I took to surgery, had negative margins, 11 centimeters with satellite nodules. CA19-9 was not markedly high. 14 lymph nodes were harvested that were negative, but 4 months later, the patient recurred in the liver. You could argue this was a futile operation, but I do think it is important for us to start thinking about this disease very much so like we do pancreas cancer, where borderline resectability can be defined not just on anatomic considerations, but also biologic and conditional patient condition. And the biology really is what I want us to kind of focus on in thinking about how to apply the studies that have been discussed already. We know that both for biliary tract cancers and for HCC, recurrence is the rule rather than the exception. Up to 75% of patients with cholangiocarcinoma will recur by 5 years, and the majority of these within the first 2 years. And we've shown, it's been shown that very early recurrence is associated with poor survival that frankly does not far exceed systemic therapy alone. And for HCC, likewise, you're going to have an equal kind of rate of recurrence at about 5 years. So clearly, surgery alone is not going to be enough. And there is interest built upon this, data to add adjuvant or neoadjuvant therapy as a means to improve recurrence-free survival or overall survival for both of these disease sites. I'm sad to report that to date, there's only been 2 quote-unquote positive trials for adjuvant or perioperative or neoadjuvant therapy in the space of biliary tract cancers or HCC. The first is the BILCAP trial, as you all know, which now identifies adjuvant capecitabine as standard of care after resection of biliary tract cancers. There are some naysayers that say that because the intention to treat didn't meet, p-value, that's a negative trial. I think, it is still going to be considered at this point standard of care to give adjuvant capecitabine. And then the other one is, I say positive, but again, this is a single arm, pretty low quality single arm study, SWOG 0809, that showed that radiation therapy may be advantageous after resection of extrahepatic and gallbladder cancer. Besides that, nothing else has borne out. And we know that inherently and intuitively, we all recognize that there are patients that for whom surgery upfront doesn't make sense. When we looked at this data in the National Cancer Database, for instance, you'll see that in 13% of patients with intrahepatic cholangiocarcinoma, a neoadjuvant therapy approach was used, absent any data to support that. So we know that all of us surgeons recognize there are features. You see here, node-positive disease, more than a third of patients receive neoadjuvant therapy first. And so we all intuitively understand that there's a need to kind of better treat the disease before we go to surgery. And the question is, which are these patients? There are features that come along and kind of tell us that these are high-risk features for disease recurrence. Node disease, of course, multifocal disease, vascular involvement. Those are all features for which we tend to think of early recurrence, high risk for recurrence, and poor survival, and therefore for us to use a neoadjuvant therapy approach. And we have shown that if you use it in the well-selected patient, you can have good outcomes. In this case, you can see our experience at Anderson of 45 patients, median survival for this cohort of high-risk disease or initially unresectable disease was 45 months, which is quite remarkable. That said, the data I've shown you so far is all retrospective, single institution, or built upon kind of like the NCDB stuff, which is not really high-quality data. So naturally, we're going to want to use agents that have been used in the metastatic setting, that work in that setting, and then try to apply it in the adjuvant and neoadjuvant perioperative setting. For instance, biliary tract cancer, ABC02 showed GemCis to be useful. Now it's being investigated, or I think accrual just completed, in ACTICA-1. Likewise, as Marina just showed, IMbrave 150 showed that atezo-bev is useful in the metastatic unresectable setting, and then it was studied in the adjuvant setting for high-risk HCC as well in IMbrave 050. So I'm going to share with you a couple of trials that we were able to get involved in for both biliary tract cancer and HCC. Again, predicated on evidence built in the metastatic unresectable disease setting. First is the NeoGAP trial. So as Dr. Biliary has already shown, this regimen was first shown to be promising in a single-arm phase 2 trial. Unfortunately, the subsequent SWOG kind of randomized trial did not demonstrate that this was a positive trial, did not show that GemCis Abraxane was better than GemCis alone. But as she said, in the locally advanced setting, there's a signal that triplet therapy may improve outcomes. And so with that in mind, we did engage in a neoadjuvant GemCis Abraxane protocol between these 4 institutions supported by the Cholangiocarcinoma Foundation and the ICRN that really aimed to show that this was feasible and safe. And again, this was a study spearheaded by Shishir, who's moderating us today, for high-risk intrahepatic cholangiocarcinoma that are resectable. So the features are shown on the screen here. And what we showed is that, yes, it is absolutely feasible and safe. All patients were able to tolerate 4 cycles of neoadjuvant therapy. And 77% ultimately were able to get through neoadjuvant therapy and surgery. If you compare that rate of being able to get through systemic therapy and surgery compared to upfront surgery series that have reported as high as 30–40% aborted resection rates, this does not, this compares pretty favorably, I would say. We also showed that disease control is pretty good in this setting, 90% disease control. And amongst patients who were resected, R1 resection rate was 27%. 73% of patients were able to get an R0 resection. Again, this compares at the very least equally, if not favorably, to upfront surgical cohorts. And again, remember, these are high-risk disease with high rate of positive nodal disease, even after neoadjuvant therapy. And then the survival data, I will be freely admitting, very disappointing recurrence-free survival, but the overall survival data so far is fairly promising. So what we learned from the NeoGAP experience is that neoadjuvant therapy, at least when it comes to chemotherapy, is feasible and safe. It does not negatively impact your ability to get to surgery, and it may allow for better chances of R0 resection. Likewise, in the HCC space, right, we know that the use of Nivo-IPI confers a survival benefit in the metastatic advanced unresectable setting, first with CheckMate 040, and then more recently with CheckMate 9DW. That showed that this regimen, as Dr. Boretti showed, is preferable over TKI. And so, likewise, we had a perioperative trial of Nivo versus Nivo-Ipi for resectable hepatocellular carcinoma. Primary endpoint being, again, safety and feasibility. The thing about some of these trials, which is nice, and I'll highlight it towards the end, is that it allows you to look at these correlatives and these exploratory endpoints, which can be of great value to us. And so what we showed with this trial primarily is that, number one, nearly all grade 3 and 4 treatment-related toxicities occurred during the adjuvant period, not the neoadjuvant period. So all the more reason to think about neoadjuvant therapy when you're talking about immunotherapy, before you do surgery rather than after. We had no treatment-related toxicity that led to cancellation of surgery. 6 patients achieved major pathological response, including 5 who had 100% tumor necrosis as a result of therapy. That's a 30% rate of major path response. And when you had major path response, no recurrence at 2 years. So key findings of this study, again, high rate of path response, major path response, treatment was safe, surgical resection was not delayed. When we studied the tumor microenvironment, we showed that there was an increase in the tumor-infiltrating lymphocytes after immunotherapy, which we think contributed to the findings and the pathologic findings that we found. And this leads to us questioning, and others as well, of course, whether we should embrace immunotherapy prior to surgery, and certainly even for resectable HCC. So what is coming down the line? What's going on next? Again, we know that immunotherapy in the setting of metastatic disease for cholangiocarcinoma has a role to play based on TOPAZ-1 and Keynote 966. With that in mind, we also have neoadjuvant or perioperative trials going on right now using those regimens. So this here is an ETCTN trial currently open at 11 sites and counting, with more opening. It's a phase 2 single-arm trial. You'll see at the bottom of this schematic here that it is very rich in correlative studies. And I think that just to emphasize this point, when you do single-arm trials, it's not necessarily all that sexy or all that groundbreaking in terms of changing the course of how we're going to treat patients. But where there is great value is the correlatives and the endpoints that you can derive, the exploratory endpoints that let you understand the mechanistic aspects of the trial, of the treatment. So this here is the ETCTN trial, and then we have a single site MD Anderson trial looking at the Keynote 966 regimen in the perioperative setting as well. But that said, that's just, systemic therapy, immunotherapy. We know that cholangiocarcinoma is a target-rich disease. And with that in mind, I know, Shashir, you've proposed this and you're building up to it, the OPTIC trial looking at taking advantage of the targetable mutations that we know these cancers to have. So for OPTIC 1, hopefully, you're looking at FGFR2 fusion. And in this situation here, you're going to be, if they do have the fusion, you're going to give them FGFR inhibitor as part of the neoadjuvant therapy. And if they're not, they're going to continue to get GAP, and then they'll get surgery. And of course, there's going to be a number of very fruitful, hopefully, correlative studies that will inform the decision and improve our understanding of this disease process and the response to treatment. And then, of course, the ideal, which you've laid out in OPTIC 2, would be to really take advantage of the mutational profile of cancers with umbrella protocol, whereby you individualize treatment in the perioperative setting based on whether or not patients have targeted mutations by giving them different agents. And then in the HCC space, likewise, there's a number of emerging neoadjuvant and adjuvant trials currently underway, including one here at Anderson. So let me just summarize by saying that it is time, though, to move beyond, certainly beyond retrospective studies, okay? Any protocol is better than no protocol because retrospective studies are very, very informative. They're very good, but they have, of course, lots of biases built into them. So how to interpret those are hard is a hard question. Single arm studies are great. They're nice. They're not enough, right? Look at the GAP story, for instance, right? In the single arm study, it was a positive, very, very kind of optimistic results. And then when you subjected it to SWOG 8 and 15, it turned out to be a negative study. So you do need to do these kind of phase 3 randomized trials to really impact change and drive decision making. Ultimately, though, I would encourage our cooperatives and research consortiums to act with nimbleness and urgency, because we can't just kind of drag everything through multiple times back and forth, because we're not going to change things at fast enough a pace. So I thank you all for your attention, and welcome questions at the end. Thanks.
Thank you, Hop. That was fantastic journey through the trial space and the neoadjuvant adjuvant space. And now we'll keep going along with that train of thought. Move on to Parissa Tabrizian, liver transplant surgeon at Mount Sinai. Huge experience with transplant at Sinai, but we've talked a lot about immunotherapy, and Hop was talking about immunotherapy around resection. We'll take it to the next level of how do you balance all of these regimens that incorporate immunotherapy with transplant that needs immunosuppression. So Dr. Tabrizian, please guide us through that train of thought.
Thank you so much for the invitation. Really an honor to be here as part of the team. So I'm going to talk about immunotherapy and the application of the data in liver transplantation, talking more about HCC than cholangiocarcinoma because we have less robust data on cholangio. These are my disclosures. So really, we've learned that tumor biology plays a crucial role in determining dropouts and long-term outcomes. It was not just simply about size and number, which the first paper from Mazzaferro alluded to, and factors such as a response to local regional therapy, the alpha-fetoprotein, what the alpha-fetoprotein dynamically does on the wait list helped predict outcomes. And based on this understanding, really, we've pushed the envelope and achieved excellent outcomes. In the early phase, there's a landmark paper by Mazzaferro, which showed a 5-year survival of 75%. Moving on to the intermediate phase, we published a few years ago a multi-center study showing that we have achieved excellent results at 10 years. Here, this is a red line in patients who were successfully downstage to within Milan. And also in the late phase stages with patients with portal vein tumor thrombus, the study from the Medanta team in India showed that excellent outcomes in this subgroup can be achieved with a 5-year survival of 57%. We've also learned, obviously, that immunotherapy has transformed HCC management, and the evidence really comes from the experience that we obtained in patients who we resected. And a recent analysis from four large studies that looked at immunotherapy in the pre-resection setting, showed promising results with an impressive 33% major pathologic response and 19% complete pathologic response. And this is a study of 109 patients. And not surprisingly, the pathologic response correlated with recurrence-free survival. So we've seen promising results with just immunotherapy and resection cases. And for transplantation, really, we could apply this for two main purposes. One is for halting progression during the wait list, and also in our downstaging patients who are at high risk for recurrence and worse outcomes given the tumor burden. If we look at the current guidelines of ASCO, ESMO, EASL, and so forth, they really do not support pre-transplant immunotherapy due to the potential toxicity risk and also rejection concerns, as well as insufficient long-term data. And there are pros and cons. One of the worries is that there's potential toxicity on the wait list as patients may drop out and not even get to transplantation. The other concern is that there's risk of rejection post-transplantation. But the pros are that we can potentially cure more patients who could have probably not gotten to transplantation, and perhaps decrease those recurrences post-transplantation and improve the outcome. The first report that was published on immunotherapy in the pre-transplant setting was terrible. It was graft loss in a patient who received immunotherapy within 8 days from transplantation. This certainly brought a lot of concern in the community. And as of last year, we really did not have any robust available data. The data we just had on immunotherapy and in the pre-transplant setting was just based on case report and case series. If you look at the different variables, there's a lot of heterogeneity in the immunotherapy type. The tumor burden also varies. The timing of immunotherapy cessation also varies. So we couldn't really draw any meaningful conclusion. Last year, thankfully, the largest retrospective study was published. This was a large-scale multi-center study from 11 Chinese centers. They put together 83 patients that they had transplanted. The median follow-up was short, was only 8 months, and there was a higher population of hepatitis B patient, and the population was sicker with BCLC C and D, and the tumor burden was also higher in this patient, where 15% had portal vein tumor thrombus. But they found a rejection rate of 27%. Just keep in mind, only 31% of these patients had a liver biopsy. And what they found for the first time is that a washout period of less than 30 days really correlated with rejection rate. So really, while this study provided, I think, valuable insight on the safety and feasibility, there were a lot of limitations, including heterogeneity. There were different types of immunotherapy that were used. The response was different. The selection criteria can be argued, and also, there was the biopsy rate was very low, so there may have been an overestimate of rejection rate in this case, but a very nice and well-designed study. A recent meta-analysis that was published this year in Journal of Hepatology put together the experience of 91 cases from 30 studies, and they reported a 26.4% rejection rate after transplantation. And they found that a median washout period of 94 months correlated with lower rejection rates, which is sort of what we had discussed at another consensus meeting with ILTS and ILCA, where we felt that a washout period of 3 months was needed in order to make this safe. Interestingly, the 80% of those rejections, if they happened, resolved with medical management, and there was no difference in survival between patients who rejected and those who did not. We finally published this year a intention to treat study. So we looked at prospectively a population of 117 patients. This is the Vitality study that we put together with multiple centers in the US. These are 117 patients that were included that had immunotherapy. And we wanted to see, what the dropout rate is, how safe transplantation is, and who gets to transplant. And some included patients who were within Milan, others included patients who were beyond Milan and who were downstage successfully. And what we found is that in patients who we transplanted, 43 of them, 3 of them were done with living donor grafts. So now there was a lot of ethical issue about using living donors, but we safely transplanted 3 of them with living donor grafts. And the explant pathology was very interesting. We found 24% of complete necrosis and 36% of over 50% necrosis. Again, keep in mind that this is a combination of local regional therapy plus immunotherapy. We had 7 rejections, 1 graft loss that was actually reported in a case report early on, which resulted in a successful retransplantation. So the patient survived. And more importantly here is that immunotherapy plus local regional therapy was safe on the wait list. There was no grade 4 and 5 adverse effects. Nobody dropped out because of toxicity. And not surprisingly here, the dropout rate was much higher in patients who had higher tumor burden. And here's the intention to treat survival and the post-LT survival, which were pretty impressive and perhaps higher than what we had seen with patients who had local regional therapy alone. Again, small cohort, but a beginning of a study. Hopefully, as the cohort increases, we're going to be able to do more analysis. One critique we had here, it was that there was diverse immunotherapy types that were used, and particularly monotherapy, such as nivolumab, that was used earlier in our experience. And in order to address this, we actually put together a study where we included 17 patients who had transplantation with just atezo-bev, which is the first-line treatment, and local regional therapy. And here, really interesting results. And if you focus on the blue color here, at baseline, a very small subgroup of patients were within Milan, here 6%. And as we added treatment, so local regional therapy, that blue color really increased to 42%. And once we added atezo-bev, because we did not get optimal results with the local regional therapy, you see how the 42% became 82%. So a lot of patients were converted to Milan, and the explant pathology, which historically showed we always seen a understaging, a 40% understaging, was very similar to what we see in the pre-transplant setting. So a lot of encouraging results. Again, very small study, but the largest study on atezo-bev and transplantation. Of course, this is all the trials that we're awaiting results, clarifying the safety and outcomes of immunotherapy in the pre-transplant setting, particularly the IMMUNO-XXL and the Plenty trial. So I'll be curious to see what the results show. Just for the sake of time, just shifting gear to cholangiocarcinoma, a couple slides on that, although we don't have much data. There may be a value in transplanting these patients with cirrhosis if they have small tumors and cannot be treated with local regional therapies or are decompensated, or patients who have non-resectable and large bulky tumors. Early data showed promising results. This is from Gonzalez Apisochin, a paper that looked at retrospectively with a multi-center study, the experience that they had on very early intrahepatic cholangiocarcinoma that were transplanted. Not surprisingly, the patients who were in the very early stage, so less than 2 centimeters, had an excellent outcome with transplantation. The 5-year recurrence rate was only 18%, and the 5-year survival was 65%. However, this data was also criticized because it was heterogeneous group. There were institutional variations. The cohort was small and it was retrospective. But I would say this is the beginning. We know that surgery is often in locally advanced cholangiocarcinoma or dismal. We also know that if they recur, most of them recur in the liver, so perhaps liver transplantation makes sense. We also know that a lot of these tumors necessitate major resection because they're in proximity of vascular and biliary structures, and not many patients can undergo major hepatectomies. And then we also have targeted therapies and neoadjuvant therapies, so perhaps a game changer and a window for open window for transplantation. There is encouraging data that was published a few years ago by the Houston group. These are patients who underwent liver transplantation for locally advanced intrahepatic cholangiocarcinoma that were treated with neoadjuvant therapy. These are patients who had intrahepatic cholangiocarcinoma alone, were biopsy proven, had neoadjuvant chemotherapy, more importantly, had disease stability for 6 months, and then were transplanted after metastatic workup was performed. And here they've shown spectacular results in the select group of patients, a 5-year survival of 57%, much higher than the patients who did not get transplanted, and a 3-year recurrence-free survival of 52%. And as a result, there was a proposal that was made to the National Review Board to allow exception points in patients who had early cholangiocarcinoma. These are unresectable cases, less than 3 centimeters, biopsy proven, and had a 6 months of therapy with tumor stability. And hopefully we can expand this to the locally advanced disease in the future. We've heard from the previous talks that immunotherapy combined with chemotherapy has shown promise in the TOPAZ-1 study and the Keynote 966 study. I won't go in detail, but it will be interesting really to see what's the implication is in the pre-transplant setting. Unfortunately, there's not robust data right now on intrahepatic cholangio immunotherapy and transplantation, but definitely something to look out for. So where do we stand? I would say in conclusion that our selection criteria continues to evolve as we incorporate biologic insights. Immunotherapy showed encouraging outcomes, particularly in HCC with liver transplantation, but we need more robust data to better understand the role of safety, the long-term oncologic outcomes, the patient selection, the washout period, the observation period, and certainly controlled trials will be crucial to further validate these findings. Thank you so much.
Excellent. Thank you so much for that. Another fantastic talk. We'll keep going through the talks again, just so we have some time for discussion. Next will be Adam Yope, who's the Chief of Surgical Oncology at UT Southwestern, also very integral and an important part of the study team for IMbrave 50. And we've talked a lot about these single institution studies, small trials, but Adam's going to really kind of take us through, probably using his experience, I imagine, in IMbrave 50. How do we come together as a national and international committee and a community to really overcome these barriers to trial enrollment, to really run the definitive trials, to really define how we treat patients? So, Dr. Yope.
Thanks, Shishir. I probably have the hardest talk to give because it's absolutely no data whatsoever, and especially after following the three previous speakers who showed all the data that there is in our field. This is just literally going to be opinion more than anything else, which is good and bad. So I'm going to be talking specifically related to hepatocellular carcinoma. And I think some of the barriers that we've had, especially within North America and South America, to enrollment in trials, and really with focusing on the non-patient factors. Some of the disclosures I have are there. So I think everybody, both on the panel and in that are listening in, just really realize what the high rates of recurrence following resection. I mean, I think in the best hands, the 5-year recurrence rate at Queen Mary published data is just over 50%. And folks or patients that recur after resection don't do very well. Some of the data, from Mount Sinai, from Parissa's group, at 21 months after recurrence. Ours is almost identical, and most large centers are very similar. So I think we need to do better, and there seems to be this bimodal recurrence following resection within the first year to 18 months, and that's mostly based on tumor factors, either tumor size, number, and then surrogates, stuff like alpha-fetoprotein, and then later on, just from the underlying disease etiology of having underlying cirrhosis. Our data, as well as others, have shown that early recurrence compared to late recurrence, late recurrence patients seem to do better. So if you're recurring within the first year after surgical resection, you're not doing very well. And that's really led to the onus of having these adjuvant trials. So there's been now 4, I would say, the largest adjuvant trials within kind of the Western world are listed here: the IMbrave 050, Checkmate, Emerald 2, and Keynote. And the first data that's read out of the 4 trials was the IMbrave 050, and I can kind of give you some of the explanation for some things. This trial obviously drew a lot of press initially and then later on as well. And just to go through the study design, pretty reasonable study design. All the other 3 adjuvant trials are very similar with the patient population. So HCC undergoing curative resection, all, child Zay, so the best of the best. All have different variations of what is considered high risk of recurrence. In IMbrave 050, we did decide to use VP1 and VP2. So some of the other trials don't. And then every trial used recurrence-free survival. So very standard in the 4 adjuvant trials. The problem is the trial was negative. I know this is sponsored by AstraZeneca, but I imagine that the next 3 trials are going to be negative as well. And so some of the criticism when we initially presented the IMbrave trial is this is a primarily Asian Pacific trial excluding Japan. So you look at the numbers here. I remember presenting this when for the interim analysis, and the big criticism was, these are not my patients. This is an Asia Pacific only study. As you can see here, these are the final inclusion criteria, the final patient characteristics from the trial. So in both groups, just over 70% are Asia Pacific, and not surprising, the vast majority of patients have hepatitis B, just over 62% in both arms. So does this really look like the patient population that we're seeing that's represented by the HPBA cohort? And I think when you dial down of why this was, it's very simple. It's in the selection of the participating sites. So there's 134 centers across the world that participated in this trial or that were study sites. 71 Asia Pacific, 63 in the rest of the world, including Japan. When you look down a little further, what kind of stands out is the centers within the United States. So there were very few centers within the United States, and I kind of blocked them right there. So you had Columbia, Henry Ford, Kaiser Permanente in LA, MD Anderson, Mercy Medical, Swedish, UT Southwestern in Texas, and Thomas Jefferson. So very few centers within the United States, very few centers within Canada. There were only 2 centers within Canada, very few centers within South America. So that is why you have the Hep B predominant patients. So this is not an I am Brave 050 or issue or kind of, it's really not an issue, but more of something to point out. In the 3 other adjuvant trials, as I list there, many more sites, but again, most of the sites are predominantly Asia Pacific. The largest number of sites within the United States is Emerald 2, the AstraZeneca trial, but very few, only 2 sites at all within Mexico, very few sites within South and Latin America. Canada, again, very few sites. So the reality is Checkmate, Emerald 2, and Keynote 937 are all going to be hepatitis B patients, essentially enrolled from Asia Pacific. The real question is why do we even care? I think the big issue with some of these trials is the constant criticism, at least within the Western world, of these are not really reflective of my patient. These are most of the patients that are seen outside of Asia Pacific are hepatitis C, alcohol, and now MASH-related cirrhosis of the dominant etiology. And I think the second thing is the neoadjuvant studies, which I'll talk about in a second, which is probably the next frontier, as the adjuvant studies likely will be all negative or won't show kind of positive, at least based on the I am Brave data. There's no reason to suspect that the other 3 trials will be positive. They'll likely will not be done in Asia Pacific due to their practice patterns. So these will need to be done within the Western world, within Europe, in the United States, Canada, and Mexico, and South America. So it is important that we talk about on-site selection, and I'll tell you why that is. And just from the United States, so the problem with doing a neoadjuvant trial and an adjuvant trial of why the site selection was predominantly Asia was this very slide. Resection for HCC is just not done. The median annual number of resections of HCC within the United States, based on the National Cancer Database from 2017 to 2021, is 1. The top center in the United States did 37 annually. And that's probably, I imagine, Mount Sinai. I know our center, both UT Southwestern University side and Parkland, are number 2 and 3, just based on the NCDB. So you're looking at very few centers are doing a lot of resections. If you did 16 a year, you are the 10th most within the United States. So if you're not doing many resections already, we know that not every single patient that we operate on is going to be eligible, or that we want to put on a neoadjuvant or adjuvant trial, is going to meet all the criteria for a variety of reasons. and number two, may not want to participate in the clinical trial. And so already it's going to be hard sledding in the early stage of whether these trials can be done in North and South America, just due to a paucity of patients. We all have, kind of the anecdotal evidence of, oh, we put a couple of patients on trial and, they've had a great response. However, within kind of the group or within the HPBA membership, there's not a lot of patients that are being resected. And so it's going to be difficult to put patients on trial. And I think it's really an incredible opportunity to utilize a mechanism of these societies, similar to kind of what the antibiotic trial for Whipple's was done and accrued very quickly to kind of educate pharmaceutical companies. So of those 7 United States sites, we were the leading site. We enrolled a total of 5 patients to the adjuvant setting. MD Anderson, top, 0. The rest of the sites, very few. And so it's probably not the big centers that you would have actually wanted to put on to encourage to be part of these trials. Now, looking at the other 3 adjuvant trials, they're very low volume centers that were actually participating sites. So it's going to be incredibly difficult to have any enrollees from the United States. However, I think it's an incredible opportunity in the neoadjuvant space, but really these trials within the United States are going to rely on pharma. The cooperative groups are not going to do these trials, but we really need to work with the pharmaceutical companies to identify sites and actually have buy-in from the surgical societies to actually get these done. I think there is an incredible rationale behind the neoadjuvant trial. I think, like I said, adjuvant probably is not going to bear fruit. And so, but I think the rationale for neoadjuvant is much stronger just because you're leaving the tumor in sight, and you're going to actually create many more T cells, that are kind of going to be more effective for therapy. And I think the Mount Sinai group has shown this, as well as some of the other data. However, these are the 3 largest trials right now for neoadjuvant. I know Mark's group has had an increase in numbers, but 15, 20, and 27, this is published data. Again, a very small amount of data, but it's an opportunity that it can be actually done. So not to be all nihilistic, there's an incredible opportunity that neoadjuvant trials present. Right now, I think there are so many questions in this space. We don't even know what the definition of resectable is. I bet of the panelists on here, we each have a different definition of what resectable HCC is, from either technical or oncologic. We don't know what borderline is. We don't know what non-resectable is based on oncologic features. We don't know how long to give therapy. How long do you give neoadjuvant therapy for? Do you give it for, now you ask Dr. Taruzian's partner, Myron will get up in front of a crowd and say one dose. That's all you need, 1 dose. Now you ask other folks and it's 3 doses. We've had arguments in national societies where no, you need 6 months. So we don't know what the duration is. We don't know which therapy to give. Ryan Fields had a question in the comments, which was great. What drugs do you give in combination with IOs? Do you just do IOs alone? Do you do the TIGIT inhibitors? Do we do the LAG-3? We don't have any idea of what to give, which is exciting, I think. Do we combine it with local regional therapy for the trials? Do we do Y90? That can only be done in the United States. You can't do Y90 in Europe because really nobody uses Y90 for a variety of reasons. And what are the endpoints? Is it pathologic response? Kind of the data initially was major pathologic response, and that was based on the TASTE data back in the day, where 70% response was considered a major pathologic response. As we've seen from the IM Brave 050 trial, do we use landmark recurrence-free survival, or is that really the issue? So there's an incredible opportunity that these neoadjuvant trials present. And, we've talked to the pharmaceutical companies in the past, and I think it's really an opportunity for cooperative groups like HPBA, HCC Live, to get together to try to answer some of these questions and to kind of hopefully to band together. But thanks so much for the opportunity. It's great to present only opinion and to actually make fun of HOP, and that's a win-win to me.
Awesome. Thank you, Adam, as always. Dr. Young can never be accused of not being honest with his thoughts. So I love it. It was a fantastic thought and a great segue, especially with your point 3 there in terms of combination with local regional therapy. So now we'll turn it over to Dr. Edward Kim, who leads the interventional oncology division at Mount Sinai, and really kind of educating us on really the importance of a multi-D approach, particularly for locally advanced disease. But even as we extend it on to metastatic and resectable, the importance of liver-directed therapies. Dr. Kim.
Thanks so much, Ashish. It's my pleasure to be here, and thank you for the invitation. I'm going to speak on TACE and TARE in the area of combination therapy. These are my disclosures. So we talk about the BCLC staging and treatment strategy, and this has been updated in 2022. And I tell people this is kind of like the Rosetta Stone. This is where multidisciplinary care really kind of comes together, and we can all speak the same language. In terms of liver-directed therapies, we know that there are different options.
Dr. Kim, I think you're sharing the wrong slide. If you the wrong screen, if you want to swap screens on top.
Okay. Thank you.
Yeah.
How's that?
Yep, perfect.
Okay. So I'm going to go back real quick. So this is the BCLC staging and treatment strategy that we're all familiar with. And this is, as I said before, is kind of like the Rosetta Stone that brings all different disciplines together so that we're talking the same language. And then when we talk about liver-directed therapies, really the highest level of evidence has been with ablation and TACE and radioembolization. TACE is, so that we're all on the same page, what we call a macroembolic therapy, where there is purposeful obstruction of the arterial flow with or without a chemotherapeutic agent. And that's what causes tumor ischemia and hypoxia and destruction of tumor. Radioembolization is a little bit different in concept, where instead of purposely obstructing the arteries and the flow to the tumor, we embed that tumor target bed with small spheres that are embedded with a beta emitter called yttrium-90. And this has a radius of 2.5 millimeters in soft tissue. So it's localized with a high dose of radiation. And by maintaining the blood flow to the area, the oxygenation potentiates the effect of the radiation. Now, in terms of where these fall in the BCLC staging and treatment strategy, really TACE and radioembolization is incorporated into the very early stage, and then TACE in the intermediate stage, based on levels of evidence and consensus for those that devise the staging system. But it's also been substratified. And so all of these patients are intermediate. So the 3 images on the left, these is a patient with lesions that potentially could be downstage to transplantation. The lesion in the middle is a large lesion with satellites. That too is also intermediate. And this multifocal infiltrative lesion without extrahepatic spread or vascular invasion and a good performance status is also intermediate. And so how do we navigate this with local regional therapies and the interplay with systemic therapy? Well, there has been some consensus, albeit with not much evidence in the intermediate stage, that diffuse and infiltrative with extensive bilobar disease should receive systemic therapy alone. And I certainly agree with that. And again, this is multidisciplinary consensus at each institution that comes to these types of conclusions. But we really need to formulate a better plan. And so this theory of combination therapy, where there's an immune suppression within the tumor microenvironment, especially within the liver, could potentially be taken advantage of and disrupted with a local regional therapy, whether it's with hypoxia or with radiation. And then that in combination with a checkpoint inhibitor could potentially lead to improved responses from the immune therapy. Now, Emerald-1 was released. It's a global double-blind placebo-controlled phase 3 study that looked at the combination in a study population that most would categorize as intermediate stage, although it did include VP1 and VP2, where patients received standard of care TACE plus single-agent durvalumab versus durvalumab followed by bevacizumab approximately 3 to 4 weeks afterwards. Not 3 to 4 weeks afterwards, but about 3 to 4 months afterwards. And then placebo alone with TACE, with the primary endpoint of progression-free survival according to RECIST, as well as the usual secondary endpoints of objective response safety. Progression-free survival was positive for the combination arm of durvalumab plus bevacizumab with TACE versus placebo and TACE alone. Durva plus TACE was also not shown to be of much benefit versus TACE alone. The progression-free survival was about 15 months with the combination therapy versus 8.2 months with TACE and placebo alone. And with MRECIST, that held roughly true as well, with 14.2 months with the combination arm versus 8.2 months with TACE alone. And so we're starting to see a signal that there could be a benefit of combination plus TACE versus TACE alone. But we are waiting the median overall survival benefit for this. One interesting note is that, again, I showed those slides to represent the heterogeneity of intermediate disease. Tumor burden at baseline, whether it was within up to 7 criteria or beyond 7 criteria, which has been devised and published by Belandi as well as by Kudo and the Japanese TACE consortium, seemed to show benefit regardless of tumor burden with the combination Durva-Bev and TACE. Now, LEAP-12 was just released as well, and this is a very similar type of study. Although this did not include any portal vein invasion in this patient population. And the tumor burden score here was devised as up to 6, between 6 to 12, and beyond 12. And this was using concurrent therapy, so started at the same time instead of successive therapy, such as with Emerald-1. And this was with pembrolizumab combination with TACE versus placebo and TACE alone. And primary endpoint was similar with progression-free survival and OS and similar secondary endpoints. Now, this also was a positive study in terms of progression-free survival according to RECIST by Bicker. Very similar outcomes, 14.6 months with the combination therapy versus 10 months alone with TACE alone, hazards ratio of 0.66. When we also look at the overall survival in pre-specified subgroups, the tumor burden here, though, is a little bit different. So those that benefited the most were those with tumor burden between 6 and 12 lesions, whereas the lower tumor burden, less than 6, did not seem to derive a benefit with a hazard ratio of 1.02. How about in the advanced stage? Well, we tend not to use TACE in the advanced stage with portal vein invasion. And systemic therapy is certainly first line and with a high level of evidence. But we do reserve radioembolization in this patient cohort with good data from Europe, Mazzaferro's group, as well as the United States, Northwestern, as well as our own experience, as well as from Asia as well. Now, Valerie Chu out of Singapore published this in Gut in 2019 about the potential immunomodulatory effects of specifically TARE, and there have been other articles with radiation therapy in general, but this was with TARE with immune checkpoint inhibitors and the upregulation and the disruption of the tumor microenvironment and the potential to use that to augment checkpoint inhibitors. And the preliminary data does seem to show there could be potential with a combination of radioembolization with immunotherapy with these studies with TARE plus nivolumab, as well as TARE plus Nivo IPI, and then TARE with nivolumab from Bruno Sangro's group, as well as Pierce Chow's group in Singapore. These are initial studies that were published with PD-1s, nivolumab in 2020. The top is from NYU, and the bottom is from our group out of Mount Sinai. It really showed that it was safe in combination with radioembolization. This was recently published in 2023 from a Korean group out of Seoul National University Hospital that had a phase 1/2a pilot trial of combining radioembolization with durvalumab with locally advanced unresectable HCC, with primary endpoint of time to progression and secondary endpoints of OS, PFS, and safety. And they enrolled 24 patients, and 23 received at least one of durvalumab. An interesting note here is that approximately 60% of patients had macrovascular invasion, approximately 60% had bilobar disease, and these were pretty large tumors with the median size of about 7.6 centimeters. In terms of their results, median time to progression is 15.2 months, median OS was not reached on this study, and median progression-free survival of 6.9 months. In terms of objective response, you can see they had an 83% objective response with a 92% disease control rate, and really minimal effects with very low grade 3, 4 toxicities. And this was recently published in the American Journal of Gastroenterology, where a national cancer database was used to identify patients with advanced HCC between 2017 and 19, and patients who received combination therapy versus, meaning immunotherapy plus Y90 versus immunotherapy alone as first-line treatment. Certainly a disparity, 142 patients with the combination Y90 immunotherapy versus 1,500 plus with the immunotherapy alone. In terms of the overall cohort, it was breaking down into alpha-fetoprotein, median tumor size being approximately 8 centimeters, and there was no statistically significant difference between the alpha-fetoprotein and median tumor size between the two arms that they studied. What they did find was associated with receipt of the combined therapy was that academic practices showed a favor in combination of Y90 and immunotherapy. When they looked at this, the overall survival, the median overall survival skewed significantly higher in the combination versus immunotherapy alone of 19.8 months versus 9.5 months. And this was statistically significant. And all the factors that they looked at were consistent across the stratified multivariable Cox analysis. And this is just to show you what is in the works now with prospective studies. There's Emerald Y90, which is radioembolization in combination with durvalumab and bevacizumab in patients with unresectable HCC. And there's also Y90 with durvalumab and tremelimumab in HCC called the Rowan study, and these are enrolling currently. So in conclusion, studies have shown that the combination of TACE and TARE to be safe with checkpoint inhibitors. Emerald 1 and LEAP 12 certainly demonstrates a PFS benefit of close to 15 months compared to TACE alone, which is about 8 to 10 months. But we're certainly awaiting the median OS data. And there's also potential synergy between TARE and checkpoint inhibition. But certainly we need further data to assess timing of the checkpoint inhibitors, multiple systemic options, and patient selection. Thank
Excellent.
you.
Thank you so much, Dr. Kim. Again, another fantastic talk. Lots of discussion about how to do these trials, but the most important perspective is the patient perspective. So Melinda Bikini, unfortunately, could not join us live due to a last-minute family emergency, but has graciously recorded her talk for us in her car and sent it in. So Jill, if you could please play Melinda's talk on the patient perspective to participating in these important trials.
Good evening. My name is Melinda Bikini. I'm the Chief Patient Officer for the Cholangiocarcinoma Foundation, and I'm happy to be here to share the patient perspective on clinical trials. I'm going to be a 15-year survivor of stage 4 cholangiocarcinoma on December 1st. I was diagnosed at age 41 and faced many challenges along the way. I'm from Montana, a rural state which made access to experts, treatments, and clinical trials difficult. I've experienced surgery, recurrence, chemotherapy, stopping all treatments for a better quality of life. But thankfully, a few weeks after stopping all treatments, I stumbled upon a clinical trial using adoptive cell therapy with tumor-infiltrating lymphocytes. I enrolled in a clinical trial at the National Cancer Institute under Dr. Steven Rosenberg. I was the first patient to have a response, and I'm so grateful to be here. I want these results for all patients. Because I have had such a great response, I wanted to find a way to pay it forward and help other patients. Because the foundation was such a vital part of my diagnosis, I began volunteering with the foundation and was fortunate enough to come on as full-time staff. I do my best to bring the patient voice to all areas of research and try to represent all cholangiocarcinoma patients and their patient experience. In 2019, with the help of Dr. Mathel and Dr. Roca, CCF distributed a 46-question survey through the PanCan and CCF networks. We received over 1,000 responses. Our aim of the survey was to better understand the beliefs, wishes, and perspectives of pancreatic and cholangiocarcinoma patients when it comes to their cancer care. And today I'm going to focus on the clinical trial portion of the survey and those results. An overwhelming 95% of patients who took this survey are open to trying experimental therapies. And over 80% are willing to participate in clinical trials. As I have learned over the years of helping patients navigate their diagnosis, we just need the opportunity to have access to and enroll in trials. And as I was willing to enter into a trial where there was no proven success, so were 60% of my fellow patients. As patients, we all feel the hope that we could be the first person to have a response, as in my case I was. When I was left with no further options for treatment, I entered with the feeling that I had absolutely nothing to lose and everything to gain. 85% of patients would enter into a trial that has high risk for the chance at better outcomes. Again, the hope for a potential better outcome is worth the risk when you have been told there's no proven treatment regimen for your cancer. 60% of patients would enter into a phase 1 clinical trial. And over 90% would be willing to participate in a phase 2 trial of a new drug being tested either alone or in combination of standard of care. And equally important, 70% would enter into a randomized phase 3 trial of standard of care versus experimental drug. But when it comes to placebos in the clinical trial setting, most patients would only enter into a trial with a placebo if there was an option to cross over after 6 weeks. Otherwise, they would not choose a placebo trial at all. I just want to emphasize that patients are hesitant to receive a placebo unless crossover is an option, but we are most definitely willing to enroll in clinical trials. I quickly wanted to touch on 2 survey results with cholangiocarcinoma patients that I was honored to be a part of. The results of these surveys were both presented as posters at GI ASCO among other conferences. The first survey was shared with all cholangiocarcinoma patients and caregivers during the 2021 CCF annual conference. The goal was to evaluate clinical trial enrollment, barriers that limit clinical trial enrollment, and biomarker testing. 204 surveys were completed by 120 patients and 84 caregivers. 57% of the population were treated with chemotherapy and 25% with a targeted therapy. 77% had biomarker testing done, in which almost 80% of the testing was requested by the treating oncologist, with about 20% of the requests coming from patients to their oncologist to order the test for them. 27% of patients enrolled in clinical trials, with 25% enrolling in at least 2 clinical trials. The top reasons for not enrolling in trials were due to not having an actionable mutation, presence of non-measurable tumors, biopsy not sufficient for testing, along with age, brain mets, and infections. In conclusion, we know that enrollment rate is still low for cholangiocarcinoma patients. We need to better evaluate eligibility criteria, which is a critical barrier to enrollment of clinical trials, and we need access to more clinical trials, expanded access programs, and better design of trials for more opportunity and hope for patients. The second survey was a collaboration between Emory, CCF, and Citizen to evaluate health-related quality of life associated with enrollment in clinical trials and receipt of targeted therapy among patients with cholangiocarcinoma. 208 patients that are engaged with CCF completed 2 validated health quality surveys, the FACT one and the COST test. 75% had intrahepatic cholangiocarcinoma, 57% underwent resection, of which 48% had disease recurrence, 22% enrolled in a clinical trial, 80% underwent biomarker testing, of which 29% received targeted therapy. This data gathered suggests that enrollment in a clinical trial or receipt of targeted therapy does not affect a patient's physical, emotional, social, or functional well-being. However, patients report higher financial burden. For patients with cholangiocarcinoma, clinical trials and personalized therapy are mainly offered late in the advanced setting, at which point a significant financial toll has already been endured. Further, they are often only available at large academic centers, creating a physical barrier to access. These findings underscore the need to increase availability and eliminate physical and financial barriers that threaten access and utilization of personalized and progressive therapies. In 2022, 211 patients signed on to the newly diagnosed program at the foundation. 65% were patients, 35% caregivers. When asked if the patients were provided with information about clinical trials by the patient's doctor or medical team, only 21% agreed, which was disappointing to hear. Patients need to have better access to clinical trials and be encouraged to enroll in clinical trials by their medical team. 82% stated they were not offered a clinical trial as a first-line treatment option. As a patient advocate, I believe patients should be told of any possibilities of participating in first-line clinical trials, including neoadjuvant clinical trials. Thank you for the opportunity to present the patient perspective on clinical trials. I appreciate the opportunity to be here.
Excellent. So you hear it, very patients are interested in these trials and really wanting to try new therapies. That was 6 fantastic talks. We only have a few minutes left for discussion. I do want to take moderator privilege a little bit here and lead 2 quick questions. The first one to Dr. Tabrizian. Maybe you could speak to us as we're developing protocols for transplantation for intrahepatic cholangio. Obviously, we have a whole listing system for HCC, but with intrahepatic cholangio, you mentioned, you get the exception points for a less than 3 centimeter intrahepatic that's unresectable. That's sometimes a hard, and still probably looking for that patient with a less than 3 centimeter tumor that's unresectable. But can you speak a little bit about what you think the ideal protocol should be for intrahepatic, the incorporation of immunotherapy for intrahepatic cholangio, particularly with a living donor program where you can actually, set the dates and how long would you stop the immunotherapy prior to try the transplant? And last comment a little bit on, has immunotherapy breached into the protocols for hilar cholangio at all yet? We had a very well-established protocol, but I haven't really seen immunotherapy really breach into that because radiation dominant. Can you just speak a little bit about that, please?
Yeah, thank you for your question. Very hard questions. I don't have great answers, but just to let you know that when we looked at our resection cases and really in smaller tumors, compared the outcomes of HCC, mixed cholangio, and intrahepatic cholangio, we really seen very similar results in the large retrospective studies. And I do think that there's a value of early stage intrahepatic cholangio and transplantation. Now, the centers who've started the protocol had a very hard time accruing those patients because, as you said, very small. You need to biopsy. They have to be cirrhotic. So it's been hard. I mean, we've had trouble as well enrolling the patients for transplantation in this case. But I know there are some centers looking into immunotherapy and cholangio and transplant, and I know the Toronto group has done few. But again, very difficult to accrue because there's small number and we don't know much. I would say, like anything like HCC, just mimicking what we've done, I think we should show good results in the early phase and then move on to the locally advanced tumors and so forth, particularly if we want to use living donors in this case. Your last question was on hilar. I personally, first of all, we're transplanting very few hilar and transplant and like without immunotherapy because it's so rare to get into transplantation. But I haven't seen any robust data on immunotherapy and hilar, to be honest with you.
Yeah. I mean, the experience with the ones who do get transplant with the radiation protocol before is so good. Yeah. It's hard to change that and expose them to the potential risks of immunotherapy in a transplant setting. Maybe to Dr. Biliary, let's expand this question to BTC as well as HCC. Mm-hmm. We've heard a lot about combination therapies, with PD-1, with VEGF inhibitors, with CTLA-4, and there was also a question in the chat about mixing targeted therapies as well. Can you speak a little bit from a medical oncology perspective as we think about neoadjuvant? Adam really kind of laid it out there. The adjuvant, adjuvant is probably slightly dead, or will be maybe dead, or at least thought to be dead right now in the HCC space. And we really need to think about the neoadjuvant setting, exposing the patient's tumors to the the immunotherapy with the antigen still present. What's the best way to do this? Should we start? Are we using atezobev? Should we be thinking about LAG-3 TIGITs right now, even as those are going on concurrently in the metastatic space and in the cholangio space? Is it just immunotherapy, or can we get a little bit more exciting and forward thinking and start bringing targeted therapy as we're trying to do with OPTIC? What are your thoughts?
So, I mean, I think the reality is that we do not know. There have been many studies in the neoadjuvant, as Dr. Ihop was showing. A lot of the studies have heterogeneity in terms of what type of systemic therapies that are used. But I think it's interesting to see that there is some consistency of results, especially when it comes to safety. I do think that as often it happens, you start with drugs that are proven efficacy in the advanced setting, and then you start to bridge them in the earlier stage. With drugs such as bevacizumab, there is always concerns, and speaking with surgery colleagues specifically about bleeding. And so you really have to have also some more concern about the timing from the last dose of, the bevacizumab and then surgery. But so far, the studies have looking at combination of PD-1, CTLA-4 inhibitors, TKI, which was in our study conducted at Hopkins with cabozantinib. Some consistency of results. I think it's going to be extremely important to dive into this initial neoadjuvant study, try to understand what are the biomarkers that emerge in terms of both response and resistance, and perhaps really leverage those data to think in a more rational way, or what is the best combination to move forward also in clinic versus just putting together drugs just because are available to us. And some of those data are emerging in terms of what are the patients that might respond, what are the mechanisms that drive resistance, which seems related to, a macrophage, enrichment in the tumor microenvironment. And I think it's also important to note that we are starting to see also perhaps surrogate endpoint that can help us understanding how the response to neoadjuvant therapy can help us to predict longer outcome. So very open questions, but I think some data that we can start to use to think about the next generations of trials.
Yeah, again, probably more questions than answers, but again, I can't thank the panelists enough. That was 6 fantastic talks. This is recorded, so I think this will get a lot of talk and a lot of airtime in terms of people really looking at this. So thank you all. I want to really give Dr. El-Saidi any final words as we close. We could talk hours in terms of how to design the right neoadjuvant therapy, the duration, the population. Adam really talked about, how to make this right trial, how to get the people enrolled in the United States, all sorts of things. So again, great data and great opinions shared in these talks. But Dr. El-Saidi, any final words? Maybe Dr. El-Saidi has. Okay, well, as we're 3 minutes past the hour, so we'll end it there to respect everyone's time. Again, this is recorded, and thank you all very much for a fascinating webinar.